Hi everyone, welcome to the Finals Crash Course series on neurology, and we'll be also covering very briefly some key ophthalmology bits as well, which will be helpful for exams. So I'm Ashwini, I'm one of the doctors doing the session, and we've got Andrew here as well, who's doing the second part of the session. And just a quick shout out to Dr. Ellie Pierce, who helped with making these slides. We got the QR code for our Instagram as well if you guys want to follow, and the email down below for anyone who wants to email us with any questions. And if anyone does want to get involved, especially next year, please do email us where we are recruiting. And just a disclaimer, all the SVAs are written by us, so they shouldn't really be used anywhere else. And we've used various resources on Google, Oxford handbooks, etc., to help make these slides. But also just check your local guidelines and things like that when you're revising. Cool. So we have a QR code here for the polls. So instead of typing in the chat this time, we have a polling app where you can just put your answers completely anonymous. So please do give it a go. And it does allow you to change your answers if you want to change your mind about it. Yeah, so I'll just let people scan the code. I'll also post a link in the chat. It works better if you have your phone in your hand. I think I can see 12 people have joined so far. I'll just give it a few more moments for more people to join. Andrew, you have access to the chat, right?
Yes, I do.
Just if you see people joining in a bit later, do you mind just reposting the poll chat link?
Yeah, that's no problem.
Well, thank you. Yeah, just give it a couple more minutes and a couple more seconds, and we'll start the session.
A margin of normal skin, but for high-risk tumours which are ill-defined or large.
Okay, so I'm going to start off now. So part one on neurology is by me. So I'm an F1 doctor in Northwest London, and this is just the first bit, and I'll be covering ophthalmology as well. Cool. So we'll start off with an SVA here. So I'll open the poll. So I'll read out the question as well. Got an 81-year-old woman who's brought to the GP by her daughter who's concerned about her memory. She says that her mother has always been very independent, but has recently been forgetting to pay the energy bills and take out her bins. On a couple of occasions, she has visited her mother, has found the gas hob has been left on by accident, and the patient insists she is well, and this is just part of getting old. What would you do first? So I'll give you about 20 to 30 seconds. About 5 more seconds. Okay, I'm going to close the poll now. So I can see most people have said D, which is the correct answer, so well done. I can see a few people have put A as well, so that is something that you can use as well, but it's more more as a bedside test, whereas the MMSE is better for this to identify dementia. So it's a bit longer, and it's got, I think you score about 30 points in it. And any score which is less than 23 indicates a likeliness of having dementia, but this alone isn't enough to diagnose someone with dementia. And all these other things you would eventually do as well. If you've suspected something like delirium, for example, you'd want to do a confusion screen, check their bloods, also do like urine samples and things like that too. If you think there's something acute going on, CT head for sure. And then the next step after suspected dementia would be sending them to a memory clinic. So just to go through Alzheimer's disease, which is one of the causes of dementia, quite common as well. So the prevalence of this increases with age. It's an insidious onset, and deterioration occurs over the course of a few years, so about 8 to 10 years. Symptoms usually start off mild, and it includes things like memory loss, kind of social and occupational functional losses as well. So you're not able to function in your job, for example, or just socially in your social groups. And for any kind of mild to moderate disease, you'd consider something like a cholinesterase inhibitor, such as donepezil. As the disease progresses, you can develop speech and motor deficits, see some personality changes as well as behavioural changes too. A lot of the first presentations tend to present as depression, so you might not pick up dementia at the start, and you might diagnose them with depression. And eventually, like I said before, you refer them to memory clinics to get a holistic assessment done on them to see what kind of interventions you can put in place. And I've just put this in here because this is quite useful, just like a nice useful infographic of the 7 A's of dementia as well, which I'm not going to go through, but it's there for your revision. Oh. So just going through some scans, because this is neurology and we like doing brain scans. So the top row just shows some healthy brains, and then the bottom row shows some severe cortical losses and loss of volume. And you can see these enlarged ventricles in here, and this is where you got that loss of cortical space there. You can see it's a lot larger than the ones at the top. And in Alzheimer's, you get these neurofibrillary tangles and amyloid plaques which form. So the neurofibrillary tangles are within the cell. Amyloid plaques are found outside the cell, and these are things you typically would only find on post-mortem. So to get a formal diagnosis, it's usually after the patient's passed away. And this is just a nice little diagram comparing a healthy brain to your severe Alzheimer's brain. Another form of dementia which gets mistaken for Alzheimer's and occasionally Parkinson's as well is Lewy body dementia. So that's also caused by protein deposits, so your alpha-synuclein deposits, which form these Lewy bodies in the brain. But the key features of this is the visual hallucinations, the Parkinsonianism, and disrupted REM sleep. So they end up getting vivid dreams, or they might sleep talk. And this is why there's kind of a bit of overlap with Parkinson's as well as Alzheimer's here too. You can also treat this with cholinesterase inhibitors or atypical antipsychotics as well. And the average survival for Lewy body dementia is about 5 years, whereas Alzheimer's can be a lot longer. Okay, so you got our next SBA here, so I'll open up the polls and read the question. Okay, so you got a 68-year-old man, Mr. Babbage, who's noticed he's become a little unsteady over the past 2 years and has fallen a couple of times at work in his accounting office. He also finds it hard to focus at work and has become a little forgetful. His wife has become concerned about his forgetfulness as he's forgotten little things like locking the car or turning the tap off after washing his hands. He also made some mistakes at work and gets defensive and aggressive when this is brought up. He has a past medical history of hypertension, type 2 diabetes, hypercholesterolemia, and ischemic heart disease. So what is the most appropriate treatment for her likely, it should be his likely diagnosis. So I'll give you about 20 seconds. Yeah, I'll give you about 5 more seconds. Okay, I'm going to stop the poll now. Oh, I can see people changing their answers. Okay, I'm going to stop it now. Okay, so most people have put down B. So I'm guessing this is from the previous question. You assume it's B, but the actual correct answer is A, which I think a very small percentage is put down. So dual antiplatelet therapy is what you'd give here, because this is most likely to be something like vascular dementia. So just a little bit about vascular dementia. So the risk factors here are usually any sort of cardiovascular things, so like hypertension. Diabetes can also put, increases the risk of getting cardiovascular disease as well and adds to it. Other things like atrial fibrillation too. You get more of a stepwise decline, and you'll have your memory preserved for the most part, but you'll see some changes in your executive, so your higher order thinking, for example, and motor function as well, so the falls that this patient's having. You also see some changes and disinhibition as well, so kind of this aggressive behavior that the patient was having, for example. And on imaging, you can see these microinfarcts. So they may not present as a stroke typically, but they'll have these minor changes due to these minor infarcts in their brains as well. And you can see these infarcts here on the scan. But it won't really cause any major physical dysfunction to them. And dual antiplatelet therapy is typically given to prevent any further vascular events from occurring, or any major events such as stroke from occurring. And other things you'd want to consider is giving them lifestyle advice, so especially diet and exercise, getting a handle on their blood pressure as well as their diabetes control too. Some patients might end up needing a carotid endarterectomy if they've got stenosis of the carotid arteries. And if they have any other sorts of dementias alongside vascular dementia, for example, Alzheimer's or Lewy body dementia, then you may consider adding on the cholinesterase inhibitors. And any psychological symptoms they may have, you would also add on SSRIs just to help control those too. So next question. So you've got a woman who phones her GP wanting advice about a 45-year-old husband who's refused to attend. Over the last few months, he's become increasingly irritable and out of character. 2 weeks ago, he lost his job for repeatedly missing deadlines. He's stopped taking care of himself, frequently wearing dirty clothes or neglecting his personal hygiene. He's usually fit and well. His mother died at an early age of dementia. Providing that he consents, which would be the most useful test in establishing a diagnosis. So I'll give you about 20 to 30 seconds. Give you about 5 more seconds. Okay, I'm going to close the poll now. Okay. So most people have put down C. I can see quite a few people put down A and B as well. So I can kind of gather what you're thinking. So PHQ-9 score might be useful to do as well for this patient. Looks like he's quite down, kind of neglectful of himself and things like that. CT head, so MRI is what's indicated here. Sorry, I'll change to the next slide. CT head's usually only done if an MRI isn't available, but the gold standard here is an MRI scan. And what we're thinking about here is Pick's disease or frontal temporal dementia. Some of these other things, so MMSE, AMTS, you might want to consider as well, but it's not the most useful thing to help with the diagnosis. So just a little bit about frontotemporal dementia. So this is typically a young age of onset, so around your kind of late 40s into your early 60s. It's got a familial link. So in this SBA, it mentioned that one of their parents died at a very young age of dementia, so very likely to be frontotemporal dementia. And you'll see these behavioural changes early on, which is due to the frontal lobe being damaged from this. And that's what kind of controls your behaviour and your higher cognitive thinking. So you get these symptoms such as disinhibition, you develop these abnormal or neat habits such as hoarding, neglecting yourself, social withdrawal, and not really focusing on your kind of day-to-day life. So work, for example, socializing, just your normal activities of daily living as well. As the disease progresses, then you can end up with things like memory loss, loss of language fluency and comprehension as well. And typical treatment for this is usually things like SSRIs or any other antipsychotics, and it's usually more to manage the symptoms itself. And I've just highlighted here as well that MRI is your gold standard for imaging. And typical survival is about 7 to 13 years. Okay. And then I've just put this table in here, which Ellie's kindly made, just comparing each of the 4 different types of dementia, which I thought would be quite useful for your revision as well, so I'd left it in there. Cool. So next SBA. Give me a second. Cool. So you got a 92-year-old lady is in hospital with urosepsis. Her daughter is concerned she has started to act strangely. She can't remember why she's in hospital, although this has been explained to her many times. She is restless and won't stay in bed in the evenings. She tells her daughter that she thinks the ward staff are poisoning her. What is the first assessment that should be done for this patient? Yeah, give you another 15 more seconds. I'll give you about 5 more seconds. It's quite funny because I can see people changing their answers. I don't know who it is, but I can see that people are changing their answers. Cool. Okay, I'm going to stop the poll now. All right, so most people have put down D, which is the correct answer. Very few have put down B and C, which aren't wrong. You would do these, but the first assessment you would do is the bedside test of just doing a very quick abbreviated mental test score. And I will be honest with you, I do not remember all the questions that you'd ask. I know the basic 6 of like age, time, date, and all that. But there's a few other little bits which are very specific to this country. So things like the Prime Minister, and like the dates for World War I or II, for example. So I'm pretty sure if I was doing this test, I would score quite low. So I put this up here just so you'd have a quick glance at it, and it's actually quite useful for OSCEs to just quickly memorize it, and then you can later forget about it, because you can always look it up on your phone as well when you're going to go assess a patient. But this is really useful at the bedside, just to kind of diagnose if there's any changes to their cognitive state. Okay. And just a little bit about delirium, because this patient clearly has delirium. It's a reversible cause of a change in your cognitive state. So the 4 key defining features are reduced awareness, change in their cognition, and not kind of keeping with their own baseline. So, for example, you might have a dementia patient who will be a bit confused, have a bit of memory loss, but that would be their baseline, and if there's any changes to that and they seem to have gotten worse, then you'd be worried. And it's really hard to differentiate, but when you know the patient well, and if you've got family members, for example, it's quite useful to talk to them so you know what their baseline is, because they can always pick out any changes in them, and you might want to you might raise some suspicions of delirium. It's usually a sudden onset, and there's evidence that they might have any sort of systemic illness, for example, so any sort of infections. If they've, especially with elderly patients, you have loads of drugs on their drug chart, for example. So polypharmacy is a big one. If they've been started on any new drugs, that might be interacting with their normal drugs. If you've stopped certain drugs, for example, but those are things that you want to just look at as well. And another thing, especially something that I've seen on general surgery, which I'm on right now, is alcohol withdrawal as well. So that's something that you want to consider as well. So you have patients who might be quite heavy drinkers coming into hospital and just obviously no access to alcohol, so just suddenly withdrawing. And then there's 2 key types of dementia. You're hyperactive, where they're a lot more aggressive, or they're a lot more vocal, they won't cooperate, they might just get up and wander. Hypoactive, where they're a lot more drowsy, they don't really interact that much, they're not really talking that much to you, they won't seem that interested in anything, they might not be interested in like eating their meals, for example, or just getting involved with like therapy, another one. And you can get a mixture of this as well, which is your 3rd type. And in this patient as well, something that was mentioned was they seem to have these symptoms towards the evening, and this is the sundowning effect, where the confusion worsens in the evening or during the night. So this is what makes night shifts really fun. I just put these infographics in there just because I thought these were quite useful. So Pinch Me is a really good mnemonic just to help you kind of identify causes of delirium. So pain, infection, any changes to nutrition, any deficiencies, for example. I'll go on to key deficiencies to look out for in a minute. Constipation. Always get loads of elderly people being put on loads of opiates, no laxatives, and they end up being constipated, which can just worsen their delirium and doesn't really help them being discharged either. Hydration, again, getting dehydrated, patient and doctors and any medical staff just end up being dehydrated. Pretty sure half of us are delirious on the wards. Medication, which I've mentioned, and just a change of environment as well. So just you might have to keep on reorientating them, because they might just be very disorientated being in a completely new environment from their own home, especially those who have been housebound for so long. They're so used to being in their own homes, they know where everything is, and you put them in a different place, like a hospital bed, for example, and they don't really know what's going on. And then got this nice little table here, just comparing delirium and dementia. And the key bit here that you should know is that delirium is acute and it's fluctuating, whereas dementia is insidious, it's a slow onset and it's progressive. And delirium is reversible. Just to quickly go through the screening. So we went through the AMTS. I mentioned doing a urine dip and just urine analysis, doing some blood. So within those bloods, you'd want to check their glucose. Maybe they're hypo or hyperglycemic. Check their thyroid function, B12 and folate, as well as iron as well, just checking for any cause of anemia. Check their magnesium, bone profile, use these, just all their electrolytes you'd want to check too. And then do a CT head as well once you ruled out everything, because they might have an acute bleed or a stroke or something which might be adding to it. For example, like with your vascular dementia, you might have some vascular changes which might be causing it, which you haven't picked up. The key thing here I just want to highlight is getting a very, very good collateral history to identify if it's delirium or dementia, or if there's actually anything going on. And management usually settles when you treat the cause, so treating whatever illness they may have, fixing any intoxication or withdrawals, reassuring the family as well, and trying to get familiar faces around them to kind of reorientate them. So it usually helps to have familiar like family members around the patient, just to help them kind of reorientate themselves as well. You can sedate them. Usually it's avoided because it can actually make the delirium worse, and it takes a while for the sedation to kick in as well, so they'll still be kicking off and you just keep adding on and eventually just completely sedate the patient, and then when that wears off, they're even worse than when they were at the start. So usually you would avoid that unless you really, really have to, and you just weigh up the risks and benefits of this. And if the patient's really causing harm and disturbance to everyone around them and harm to themselves, then you'd consider and always reassess them to see if they're actually improving or getting worse too. And people, especially those who frequently end up delirious, are at higher risk of getting dementia in the future. Okay, next slide. So got the next SBA here. So a 64-year-old male, Mr. Pingu, was sitting and watching TV one evening when he noticed he couldn't lift his left arm. When he stood up, it drooped to his side, and he described it as if it were dead. He became increasingly worried and called an ambulance and was taken to hospital. On examination, he had no other motor signs apart from the left arm weakness. Sensation was intact. It resolved after an hour of being in A&E. What is the most likely cause of his clinical presentation? So I'll give you about 20 seconds. I think a lot of people have already put their answers in, so I'll give about 20 seconds. About 5 more seconds. Okay, I'm going to close the poll now. So I think this is the SBA that everyone likes, because the answer is staring at you in the face, because everyone answered A, which is correct. So well done, guys. So yeah, this patient has a TIA, and the key bit here is that it's self-resolving and it's within 24 hours. So just a little bit about TIA versus stroke. So TIA is a transient episode which causes some neurological dysfunction. So that in this case, it was his arm, but there's no actual infarct itself. So there's a blockage, and then it resolves itself as the brain gets reperfused, and that's where you get the resolution to the symptoms too. Whereas strokes, a cerebrovascular accident, It's sudden and it's an interruption of the actual supply, the blood supply to the brain, and it can lead to irreversible damages. And the two main types are ischemic and hemorrhagic, and ischemic being the most common. Okay, so I'm going to go into a bit more, but I've got one more SPA here before we do. So bring up the polls. So same patient, same presentation, but where's the occlusion likely to be? So I'll give you a bit longer here to have a think about it, so about 30 seconds. Give you about, I'll give you 10 more seconds. I don't think most people have answered yet. About 5 more seconds, just wary of time, so don't want to leave it too long. Okay. All right, I'm going to stop the poll now. So I can see most people have put down B. The answer is actually A, so well done to the minority who put down A. I can see some people have put down D as well, so we'll go over this. So put this lovely diagram in here, just covering the different vascular territories. I think trying to pinpoint the exact location of the infarct isn't always easy, especially because there's a lot of overlap with some of the symptoms that you can get. So the reason why this is an anterior cerebral artery occlusion is because this shows you present with something like a lower limb or an upper limb paresis. You can get some gait ataxia, bladder incontinence, personality changes and behavioral changes as well. So for this patient, it was just his arm. Then with an MCA, which was the most common answer, this is more, you get deficits of the arm, leg, as well as the face. So the face isn't involved here that much. It's just the arm, which is why it goes. It's more likely to be an ACA and not an MCA. With an MCA as well, you get changes to your eye movements as well, and you can get this kind of gaze deviation to endotheltria. With the posterior cerebral artery infarct, so your PCA, it's usually pure homonymous hemianopia. You get some nausea and vomiting with it. There's vertigo, weakness, any sort of sensory losses as well. And then your lacunar ones are usually kind of in around the region of the thalamus. So any alterations to your senses, pain, changes to your touch sensation as well, so temperature, crude touch, and you can get contralateral hemiplegia too. Cool. So this slide, I can kind of spend ages going over this, but the slide's available, and I've put a really good comprehensive kind of explanation of each of the territories in the notes as well. So when you have access to it, you can read through that. Unfortunately, we don't have time to sit here going through every little bit, but I've just kind of highlighted why it's an ACA and not an MCA mainly here. Oh, this is another key thing that you guys need to know is the NIHS score. So this is what's used to kind of measure the level of impairment you get from a stroke. And this is also used to evaluate if a patient is a candidate for thrombolysis. And typically for thrombolysis, it has to be within 4.5 hours of onset of the symptoms. So if they have symptoms and their score is less than 4, they're likely to have a good outcome. 5 to 15 is a moderate kind of stroke. 16 to 20 is moderate to severe, and anything above 21 is a severe stroke. And you'd kind of assess them and look at the full clinical picture of what their baseline is, how they are functionally, their comorbidities as well, to decide if they are a good candidate or not. And then this is the other one that you want to know, is the Blanchard stroke classification. So the key features, especially looking at your total anterior circulation strokes and your partial anterior circulation strokes, are your unilateral weakness with or without the sensory defects. And when you say anterior, you also include the MCA in that, because that's the anterior part of the brain. You can get homonymous hemianopias and any sort of higher function issues such as dysphagia or visual spatial issues too. So for it to be a tax, it has to cover all 3 of those criteria. For a PAX, it's just 2 of those. And then you've got the criteria for the lacuna infarcts and your posterior circulation infarcts here as well. So the lacuna ones are usually purely sensory or purely motor. And that's the key defining features there. And then for posterior, it depends on the location. And you just need to have one of the following these kind of affecting your motor or sensory bilaterally, or kind of your eye movements, or kind of cerebellar dysfunction, for example, as well. And then just to quickly go over differences between ischemic and hemorrhagic. So ischemic is where you get the blockage of the vessel, whereas hemorrhagic is where your blood vessel actually bursts. And the common cause, one of the common causes for hemorrhagic strokes is usually something like an aneurysm. And your hemorrhagic can be either intracerebral or your subarachnoid hemorrhages, or also classed under hemorrhagic strokes. Risk factors of age and hypertension overlap here, but for ischemic, smoking, hyperlipidemia, diabetes are key risk factors, because that increases the risk of forming and throwing off any thrombus or any emboli. And AF is another risk factor, because you can also produce these blood clots in your heart, which can be thrown off and block off vessels. And then for hemorrhagic, if a patient's got any sort of arterial venous malformation, if they're on anticoagulation therapies as well, that increases the risk of bleeding and causing brain bleeds. Cool. I put this image in here just so you can kind of see the difference between what you see on CT. So this is your ischemic, which is hypo attenuating. So you can see that region of the brain which is completely ischemic and dead. And that's hemorrhagic. So that's your hyper attenuating. So fluid comes out as a bit white. So that's your bleed in the brain there. Okay, so just quickly go over management. So for TIA, you'd offer them 300 milligrams of aspirin for about 14 days. And then you'd also refer them to TIA clinic, and they have to be seen within about 7 days. You do an MRI as well, just to check out for any other blocks. Do a carotid ultrasound, and then maybe have to refer them for an endarterectomy. And then secondary prevention is giving them 75 milligrams of aspirin if it's a confirmed TIA. And this is just to prevent any further episodes and any development into a stroke as well. With stroke, you do a CT head without contrast, and this is done straight away if you have a suspected stroke, because you need to identify if it's hemorrhagic or if it's ischemic to know if you want to thrombolize the patient, because you don't want to thrombolize them if it ends up being hemorrhagic, and that will just cause more of an issue. So if it's ischemic, you can see if there's an indication for thrombolysis. Typically onset is within 4.5 hours of the onset of the symptoms. So that's why when the patient comes in, it's really important to ask them at what time did they notice these symptoms. And a lot of the time, if they've woken up with it and they've come into hospital an hour later, you wouldn't really consider thrombolysis because you don't know if the stroke happened in their sleep. Then you'd go on and give them 300 milligrams of aspirin stat, give them oxygen if the saturations are low, do bloods on them, do an ECG, check their blood pressure as well. For hemorrhagic, you'd refer them to neurosurgery, get their input for any further management. Otherwise, if they don't think any surgical management is required, then it's all about supportive care. You stop any anticoagulations, antiplatelets to stop adding to the bleediness of the patient as well. And then eventually you'd kind of go on to this sort of doing physio and having an OT input as well, and go through rehab to try and get them back to their baseline as much as possible. And most of the time it's an MDT approach with the medical team and the rehab team kind of working together to help these patients kind of get back to their baseline and get back to their normal day-to-day life. And if they can't, then you'd kind of consider adding like a package of care or support or things like that once they go back home. And then just a little quick note on thrombectomy, where they go in and actually remove the clot. There's a potential to help salvage the brain tissue. Then you'd kind of do a risk-benefit way up. And if the NIHS score is over 5 and the patient themselves are a good candidate, then you would consider this. And I've only seen 2 patients who've had this before, and they were both very young patients. I'm pretty sure one of them was under 40 and the other one was like in their mid-40s, who'd had this because they were quite young, fit, healthy, just happened to have a stroke. Okay, and then just quick whiz through subarachnoid hemorrhages. So listed the risk factors here, which are very similar to strokes in general. The key clinical feature you want to know is that it's a sudden onset thunderclap headache that they get. They'll also end up with things like meningism, have a mass effect as well, so this increase in intracranial pressure, and they may have focal neurological signs, and key one is cranial nerve 3 palsy, and these are key things that they have in the questions when you have your SBAs. Investigation, CT head, like all of the strokes, you might consider doing an LP, and a CT angiogram as well of the brain. Cool. And if the intracranial bleed or subarachnoid hemorrhage is due to an aneurysm, there is an increased risk of rebleeding, so you'd want a quick intervention, refer to neurosurgery and see if they can either clip the aneurysm. Other things you want to consider is giving things like nimpodipine for 21 days just to prevent any vasospasm, ensure that the blood pressure is controlled as well, and also stop any anticoagulation treatment that they're on, and maybe even consider reversing them. And just complications of these are rebleeding, especially within the first 12 to 24 hours, hydrocephalus, developing SIADH with any sort of head trauma, vasospasm, seizures, and of course death is always a risk factor for any of these. Okay, and I just listed the different causes of intracranial intracerebral hemorrhages here as well for you guys. So just add on things like tumours, for example, hypertension, trauma, and any kind of cerebral amyloid angiopathies as well. Cool. And just a quick word on rehab, which I've sort of mentioned. It's the key principle here is just to help them recover from any sort of neurological injuries. So strokes are big ones here. It's an MDT approach, and it's usually within the hospital. Whilst they're inpatients, they'll be seen by the rehab team, and they can either be sent off to inpatient rehab somewhere else in a specialist centre, or they can have community visits as well. And a lot of the time it's just kind of reviewing them in clinic again if they're actually well enough and able enough to look after themselves or have enough support at home. And this is just a little mind map of the different kind of things that you can have as part of the rehab process. Oh, so I've got the next SBA here, so I'll open up the poll. Okay, so you got a 24-year-old man, Ruben, got into a brawl one afternoon after his team lost the rugby match. He fell unconscious shortly after a unwitnessed injury, but regained consciousness a short while later. Later on during the evening, he developed a headache and started vomiting repeatedly. He then fell unconscious and started shaking. His partner called an ambulance in a panic. What's the most likely diagnosis? Okay, I'll give you about 20 seconds. You can see quite a few people have answered already. Okay, give it 5 more seconds. Okay, I'm going to close the poll now. Okay, so I can see a very big majority of you have put down E, which is the correct answer, so well done. So it is an extradural hemorrhage. Key features here. Ooh, sorry. Okay. So key features in this is that he's had an injury, very likely a head injury because he lost consciousness, but can't be predicted here. But it's the fact that he lost consciousness, he got up, he was fine, so he had this kind of lucid period, and then he started deteriorating. So he started vomiting, he fell unconscious again, started shaking, so likely he had a bit of a seizure as well. So just to go through extradural hematomas. So extradural hematomas are basically defined by the suture lines between the skull and the dura, and it forms this kind of lentiform shape, or I'd like to think of it as a lemon. So it's like a lemon shape there. Whereas your subdurals look like a banana. And we'll come on to that in a bit. So usually caused by head trauma, which like here, risk factors are usually young, male, and any sort of contact sports. And the most common site is usually the temporal region and the bone fragment. Just mentioning this because it has come up in loads of practice questions I've seen, is the terion, and it ruptures your middle meningeal artery, which is a branch of the maxillary and the external carotid. It's just a key fact to remember for any of these SBAs that might come up for you guys. So I've gone through the clinical presentation. Just one more thing to add to it is this fixed dilated pupils and your Cushing's reflex as well. And they can also end up in a coma. So in terms of management, it's an ATE approach. Check their GCS. Low GCS, if they're unconscious, not responsive, then you'd intubate. So any GCS below 8, you'd consider intubation, but it does not mean you have to intubate them because the actual presentation might not reflect the number, which is why it's always useful to break down the GCS into your EVM. And if you had any sort of head trauma or any trauma, you'd want to also immobilize the C-spine until you know that's actually stable. Again, CT heads, C-spine X-ray or CT as well within time they arrive, at 1 hour and then at 8 hours as well, to make sure it's not worsening. You'd want to do neuro obs on them. So you do obs on them every 30 minutes until their GCS is 15, and then you do 30 minutes for 2 hours, 1 hourly for 4 hours, and then you do 2 hourly obs. and that usually continues for about 48 hours. And if it's an emergency and if there's any indication, then you can do emergency evacuation using a burr hole or a craniotomy. Okay, next question. Can see a question in there. Give me 1 second. Let me read it properly. Just getting the chat up on my phone. So what is the Cushing's reflex? Okay, so the Cushing's reflex is usually due to kind of the increase in that intracranial pressure. So you can imagine having a hematoma. So this applies to any sort of brain bleed, increased intracranial pressure, where you've got that increased pressure kind of pushing down on your brain. And you get this sort of triad of increased blood pressure, bradycardia as well. I can't remember what the third one is. I think it's something to do with your respiration rate. See that it increases your rest rate, or it's like irregular or something like that as well. So this is the key triad. I can look it up and then put it in the chat later on just to confirm. I hope that answers your question. I'll look it up once I'm done properly. But I remember it's like a triad of like increasing the blood pressure and being bradycardic, and I'm pretty sure it's higher rest rate as well. Okay, so just going to open up the next poll for this. So next one, got an 80-year-old lady, Betty, who was brought into the GP by her son. She states that his mother seems to have become more confused over the past few weeks and noticed that over the recent weeks she has become more sleepy and unarousable. She has a past medical history of hypertension for which she takes amlodipine. She smokes 10 a day for the past 50 years and drinks a glass of wine every evening. What is the most likely diagnosis? So I'll give you about 30 seconds. Okay, about 5 more seconds. Okay, all right, I'm going to stop the poll now. Oh, okay. Cool, I can see majority have put down C, which is the correct answer. So yeah, this is a subdural hemorrhage. So the key bit here is that it's a bit of a slow insidious onset, which has happened over a few weeks now. She's also got this kind of low GCS, so she's a lot more sleepy, unarousable, a lot drowsy. She's had some, she's probably had some cognitive issues as well here. So this kind of confusion, possible memory loss due, and any sort of changes to her personality. That's what kind of helps differentiate. Whereas with your extradural, it was you had the head injury, had a lucid state, and then suddenly started deteriorating. Whereas this is kind of gradual. And next slide. There we go. And then put a CT in here, so you can see this kind of you can see the hematoma here. So that is your kind of banana shape, because it goes across the suture line and it kind of fills up that half of the brain here. So it can go all the way up to the suture line here. And you can see that sort of midline shift as well, which was also the case with the previous image for the extradural. This is a bit more clear because you can actually see the ventricles here. And you do a CT mainly to look for this midline shift, to see the mass effect. Look at the size of the hematoma, and you repeat the CTs to look for stability of that as well, to see if it's increasing, worsening, for example, or if it's actually resolving and decreasing and getting better. And then subdural hematomas are divided into acute and chronic. So acute is usually it's happened within 4 days, likely due to like a high impact trauma. Subacute is between these, so 14 to 21 days, and then chronic is weeks to months. Like in this picture, for example, it's been going on for weeks, so by the time it's been picked up, it's probably a chronic subdural by then. And the chronic ones are usually caused by like anticoagulation use, for example. Other risk factors include like age, maybe had a bit of a fall, but it wasn't really a high impact fall. Chronic alcohol use as well is another one. So you might see questions where they have someone who is a very heavy drinker ends up with a subdural, for example. And quite a few of them can be idiopathics too. So clinical presentation, we've gone through the one for chronic, but for clinical, you'll get this headache, nausea and vomiting, exacerbation when you're straining, for example, when you're coughing and things like that. You'll see these focal neurological signs and a possible coning effect too. Management is obviously doing a series of CT heads, doing your neuro-obs, so there's 48-hour monitoring and doing that series of neuro-obs on them, and then you might want to consider surgical decompression, so always refer to neurosurgeons for any sort of brain bleeds and see what they say. Okay. Yeah, and also just this image here, you've got your subdural here just highlighted and your epidural, so that's forming a lemon, that's forming like a banana basically. So your next SBA. So just opening up the polls. So you got 19-year-old female university student Becky is brought into A&E. She has a 7-hour history of a headache, photophobia, and neck stiffness. She also had a fever and developed non-blanching rash on her torso. Her meningitis is suspected. Which organism is the most common cause of meningitis in young adults? So I'll give you about 30 seconds for this. Five more seconds. Okay, I'm going to close the poll. Okay, so most people have put down B, which is the correct answer. So Neisseria meningitis is the most common cause of meningitis in this age group. The other ones which you can see, I think very few people put this down as an option, is Streptococcus pneumoniae, but it's not the most common, but you can see it in this age group as well. So this table is quite useful just to kind of know the different organisms for different age groups, and I've also put the common viral causes here as well, just for you guys, for your learning. But I'm not going to go into too much detail on all the kind of microorganisms here. Just to quickly go through the management though. Initial approach, ATE, always do an ATE approach with anything neurological. Do your blood cultures, do a PCR as well, just look for any organisms. CT head to rule out any other causes. Swab them, chest x-ray, and also want to do a lumbar puncture unless they've got raised intracranial pressure, because then that's a risk of coning. And then you'd also send off the CSF for microscopy, as well as looking at everything else in there too. And then this table here, I'm sure a lot of you have seen this before. Just it's really useful to just know how to differentiate what normal CSF should look like. So it's usually straw-like, That's your glucose levels in there. If it's got bacteria in there, glucose is usually low. It's looking more turbid because bacteria is causing that turbid appearance. And the way I remember it is bacteria uses up energy, so it needs that glucose, which is why the glucose is low. And it also produces proteins, which kind of gets rid of it from itself, which is why the protein gets high. And then your viral one, you can't really see viruses, so that's why it's clear. It doesn't add anything to it, so your protein is going to be low. It doesn't use up glucose, which is why it's normal as well. And then you've got your fungal or TB, which forms these fibrin webs, which is different from the actual turbid appearance you see in bacteria. Your glucose levels, it will use up a little bit, but not as much as bacterial, so it's just it might be a bit higher than what you see in bacterial meningitis, and you might get a little bit increase in protein as well, but not a significant increase. Okay. Okay, and then treatment. Key one, especially if you're in GP setting, is bend pen. Give them IM, and you can give it IV in hospital. IV ceftriaxone, and in certain age groups, so less than 3 months, and if they're older than 55 years, you can also add on ampicillin. Other things that you want to consider is IV acyclovir if you think it's a viral cause. IV dexamethasone, it's another one that you'd consider as well. And always give them general supportive treatment and consider ITU support as well if needed. And this is a notifiable disease. And if they've travelled abroad, then you'd also want to consider vancomycin as an option here. And complications of meningitis includes things like hearing loss, any acquired brain injuries, learning or behavioural difficulties which may develop, partial loss of vision or complete blindness in some cases if they're unfortunate. And you can also end up with various other infections like sepsis, abscesses or encephalitis, which I'm going to go on to in a minute. And also it can increase your intracranial pressure too. Okay, so encephalitis. So key clinical features here is fever, headache, nausea and vomiting. It can kind of seem similar to your meningitis. I think one of the key things is you can get psychiatric symptoms here, and seizures is another one, and it typically affects the temporal or the inferior frontal lobe, so the lower bits of the brain. Common causes is like varicella zoster if you're immunocompromised, or HSV1, which is 95% of the cause. Other organisms are quite rare. And here you can see the CT scan. So that's one of your investigations, and you can see that kind of enhancement of the temporal lobes. On top of CT, you'd also do like an LP, get a CSF analysis done, do an EEG as well. And if it's getting worse despite any treatment, you'd also maybe consider a brain biopsy too. And then treatment, if it's mild, just general analgesia and antipyrexial, so paracetamol, ibuprofen, give them fluid, ensure they rest enough and hope it self-resolves. If it's moderate to severe, then that's when you start considering your antivirals. And depending on the organism and what's going on, you might start kind of considering some more fancy antimicrobials for them too. Plasmapheresis is another one, corticosteroids, and also if they're having seizures, then consider anticonvulsants, and phenytoin is the key one that you'd use, and you'd want an MDT input as well. Cool. And then just going on to brain abscesses. So common organisms are your strep pyogenes from sinusitis, Staph aureus from any sort of traumas or surgeries that you may have had. If it's embolic, so if you've got endocarditis, it's thrown off this little ball of an unfortunate ball of like bacteria or something. And if they're immunocompromised, especially patients with like HIV, for example, you can also get fungal causes too. And on the CT, you can see these like ring enhancing lesions here where the abscess is. So just point it out for you guys. Clinical presentation is usually like this dull, persistent headache. They can have swinging fevers. They might have some focal neurology, especially due to the raised intracranial pressure. So cranial 3 or 6 palsies, and then nausea, vomiting, papilledema, and any such seizures, and anything kind of linked to having a raised intracranial pressure. So CTs obviously, or MRI is one of your main investigations. You want to source what the infection is, so you can have a CT guided aspiration of the abscess itself, and you can send that off for cultures. Then treatment itself is giving them IV antibiotics. So third generation cephalosporins, metronidazole and vancomycin are ones that you want to consider to decrease the intracranial pressure, dexamethasone, and then you can consider surgical debridement and drainage of this. So it's usually surgery is done if it's over 2 centimeters. If it's easy access, they usually avoid it if it's deep, and if they've got like meningitis and hydrocephalus as well. Okay, next question. So the patient is not responsive to voice. They do not open their eyes to pain, but they tense their arms in bed and groan. What is the patient's GCS? So I'll give you about 30 seconds. Might give you a bit longer than that actually, just so you can work it out. Okay, I'll give you about 5 more seconds. I'm just a bit conscious of time. Okay, I'm going to close the poll now. Okay, so most people have put down C. Got a few people saying B and D as well. So I hated these questions because I always jump between, especially when the numbers are really close together, is really off-putting because you don't really know what you want to consider here. So if we calculate this together, so we've got a patient here who's not responding to voice at all. So this is automatically kind of, you don't say that there's no verbal response here, but then here you're saying that they're not opening their eyes to pain, but they're tensing. So their eyes aren't opening, so you get 1 point. They're groaning, so that's your incomprehensible sounds. That's your 2 points, so that's 3 there. And then they're tensing their arms. So this is where it gets a bit tricky. So it's their extensors which causes that rigid response. So that's your tensing. So that's another 2 points, which is what makes it 5. Okay, so I think it's usually the motor response where you kind of get a bit confused. That's where I always got confused about. So it's just kind of remembering if they're going a bit more rigid, then it's 2 points. If they're flexing, but it's not like actually withdrawing from the pain, then that's 3 points. If they're withdrawing from the pain, it's 4 points. And if they're actually making proper movements when you're causing pain, like pushing you away, for example, 5 points. And if they're just moving their arms spontaneously when you tell them to, then that's 6 points. And the lowest GCS you can have is 3, because the minimum points is always 1. It's never 0. Okay, and then I just put this table here just to kind of go through mild, moderate and severe. But again, the number doesn't always reflect the clinical picture. And I added in this little infographic because I like my cartoons from sketchymedicine.com, which I actually use quite a lot when I was at uni. And it's quite useful just kind of to see and visualize what you expect for each score. Okay, next SBA. So open up the poll. Okay, so you got a 45-year-old man who presents with headaches and visual changes. He also noticed that his gloves don't fit as well, and his wife has commented that his jaw seems more prominent. You suspect acromegaly secondary to a pituitary tumour. Which visual field defect would you expect in this patient? So I'll give you about 20 seconds because I can see a lot of people have already answered. Okay, about 5 more seconds. Okay, I'm going to close the poll now. Okay, so everyone's put down A, which is the correct answer, so well done. Another one of my favourite questions where the answer is actually screaming at you. So, if you know your anatomy well, you know the pituitary gland sits right above the octave chiasm, which is what causes this visual field defect of bitemporal hemianopia. So, typical presentation of pituitary tumours is usually headaches, visual field defects, and nerve palsies as well if it gets any bigger. And it can also start affecting pituitary function, leading to deficiencies. And here, the acromegaly suggests it's a growth hormone secreting pituitary tumour. So, not going to go through everything. But this diagram I found really useful, and this is something that I've kind of kept in my notes because I found it very useful. Just going through the different defects and where the lesions would be in the visual field. So that's your optic chiasm. So you can. I'm just going to go through the one specific to this SBA. So this is your temporal visual field, and when you're colouring these circles in, you're shading out the bit which you can't see. So the actual peripheral bit is actually on this more nasal side of the eye, which then crosses over at the optic chiasm. And same thing on this side, crosses over, which is why it's both peripheral bits which you don't see, which is why it's bitemporal hemianopia. And just one other thing which I just want to mention, because this is something that it took me a while to get around my head, is the macula sparing. So your occipital pole, if there's any sort of posterior cerebral artery occlusion, it does get a collateral flow from the middle cerebral artery, sorry, which is why you get that macula sparing with strokes, even though you have this homonymous hemianopia as well. Cool. And then it's just, this is quite easy to follow because you can just follow the different colours of the fibres to see where it's going. So you can have a look at this in your own time. Just quickly whiz through pituitary tumours. So presentation I've gone through already. Just treatment is usually surgical and radiotherapy, or you can also give them hormone blockers. So growth hormone, you get acromegaly, you get with headaches, hypertension, cardiomegaly as well because of growth hormone that's being secreted. ACTH can give you this Cushingoid presentation. Prolactinomas, so producing prolactin, you can actually treat that with dopamine agonists, such as carbodylene or bromocriptine, and the presentation is usually something like galacturia, so secretions from the breast, and TSH as your you can get thyrotoxicosis, and this is secondary thyrotoxicosis. So if you go back to the endocrine lecture that was done, it kind of goes into more detail about the thyroid function tests and how to interpret them. And your LH and FSH producing tumours are usually non-functioning tumours. Okay, and then I just put this table together just so you can kind of see what the deficiencies are, where when you have one tumour and that one like hormone producing tumour in the pituitary and how that causes these deficiencies. So you can go through this in your own time. And I've just put a line for different treatments that you can give as well if they've got a deficiency. Okay, so next question, we're getting towards the end of my bit slowly. So you've got a 40-year-old woman who has worsening headaches over the past year. Headaches are worse on waking and better when she gets up out of bed. Examination is unremarkable. Family history reveals relatives with brain tumours and a cousin with neurofibromatosis, can never say that one, type 2. CT head is done for this patient. You suspect a brain tumour. What is the likely diagnosis? Okay, give you about 30 seconds. So for this one, you kind of need to look at the CT head. It's not a very nice one to give you guys. It's a bit mean. I'll give you about 5 more seconds. Okay. I'm going to close the poll now. Okay, so it was an even split between A and B, but A seemed to have won. But the answer is actually B, and I will tell you why. So it's a meningioma because it's a dural-based tumour. So you can see the tumour is actually kind of pushing through from the dura itself, which is why it's a meningioma. And they tend to be hyper-attenuating. So you can see that it's a bit lighter than the rest of the brain. And with contrast, you can get it to enhance on CT as well. So this is a non-contrast CT. And there'll be usually like kind of perilesional edema around it. So you can't really see it clearly on this image just because it's been copied and enlarged, but there is a bit of edema around it too. So with glioblastomas, they're usually widespread, they're low attenuating, and sometimes it's actually normal on a CT scan. Vestibular schwannomas tend to present with a bit of hearing loss as well. Craniopharyngiomas are skull-based enlargements, and it also includes a kind of erosion or any sort of involvement of the sella tunica or the dorsum sella. And then your medulloblastomas are solid tumours usually found around or near the cerebellum itself. So you don't need to know too much about it. It's just more about the general approach and the general presentation of brain tumours at this stage. So this was a bit of a mean question to kind of put in there, but it is good to know how to differentiate between each of them as well. But you won't need to, you wouldn't be expected to actually look at CT and kind of differentiate it that way. Okay, so just going through quickly with general approach. So you look at the presentation, look at their cognitive, psychological and physical symptoms as well. And each of those can be affected depending on the location of the mass as well. You can get visual defects and cranial nerve palsies, especially with the location of the tumour as well as the mass effect, which can eventually develop. Spinal tumours present with kind of focal neurological symptoms. It depends on the nerve root or if they've got spinal cord compression. Investigations, standard CT, MRI. You might want to consider some functional imaging like SPECT or PET scans, just to assess them, and then also assess them for treatment response too. Consider histology, getting a biopsy or something, and then things like LP, CFS, cytology, HIV, checking for that, blood, pituitary function, and just genetics as well, because Menin syndromes can be linked to some brain tumours as well. So in this case, it mentioned what neurofibromatosis, which is linked to meningiomas. Okay, and then you've got different treatments. So it's a general MDT approach with a lot of neurological conditions. So in case of tumours, you get a neurosurgeon as well as a neurologist involved, and then you have neuro-oncologist, you've got your clinical nurse specialist, and you've got the whole rehab team involved too. You may consider some surgical intervention depending on the location if it's got easy access and minimal disruption to the remaining structures. Chemotherapy and radiotherapy, and then if none of these are good enough there, or if you can't actually do anything about tumours, then palliative care is the next step. And brain mets are most common kind of types of brain tumours that you actually get, and a lot of them are untreatable because you get a lot multiple brain tumours, and a lot of the mets typically come from these kind of key 5 organs, so your lungs, breast, bowel, from melanomas, so skin cancers, and then your kidneys as well. Okay. And then I've just put this table in here just for your revision, so you can have a read through later on just how to differentiate between each of the different, so the 5 main tumours that wouldn't normally get covered in finals. So next question. So a patient comes in with sudden onset headache. A CT head shows a possible aneurysm. You also note on examination his right eye is displaced down and laterally. Which nerve is likely to be affected to result the examination findings? I'll give you about 20 seconds. Okay. Give you about 5 more seconds. Okay, I'm going to close the poll now. So I can see most people have put down B, which is the correct answer, so well done. So the oculomotor nerve is the one that supplies the medial rectus, the superior rectus, the inferior rectus, and the inferior oblique. And these muscles pull the eye inwards, so towards your nose, and upwards towards your forehead. So any damage to this is going to make it go in the opposite direction, so moving it downwards and away from your nose, so going out. So that's why you get this down and out with a oculomotor nerve palsy, so your cranial nerve 3 palsy. So your trochlear nerve supplies the superior oblique, and that's the one that pulls it down and in. So that's towards your nose and looking kind of down at the tip of your nose. And this usually, any kind of damage to this or any palsy would make it difficult for you to kind of look towards the midline and downwards. And that's your cranial nerve 4. And then abducens is cranial nerve 6, which supplies the lateral rectus. So this helps the eyes move outwards, so hence the lateral. That's how I remembered that one. And so that your eyes start moving medially, so towards your nose, so that if both eye cranial nerve 6 branches of damage, you can get this kind of cross-eyed appearance as well. And then any sort of optic nerve damage, so your second cranial nerve, would result in visual field defects. And trigeminal nerve also supplies the eyes, but this is more sensory, and or just result in pain, and it's usually pain around the face and the skin around the eyes typically. Okay, next SBA. So opening up the poll. So there's just 2 more questions in here. So we've got a patient who coming in complaining of pain in their left eye. They also have photophobia, decreased vision in the affected eyes. On examination, you note they have small and a poorly reactive pupil in the left eye and redness. Fundoscopy shows the retina is healthy. The right eye is normal. There is no discharge or crusting around the eye. They're given steroid eye drops along with cyclophenolate eye drops. What is the likely cause of the patient's unilateral eye pathology? Okay, I'll give you about 20 seconds here. About 5 more seconds. Okay, I'm going to close the poll now. So, majority have put down C, which is the correct answer, so well done. So, anterior uveitis is usually presenting like unilaterally, which rules out conjunctivitis. And with conjunctivitis, you're likely to get discharge, and it's bilateral because you end up with infection in both eyes eventually. With keratinitis, you'd get this cloudy appearance of the cornea, and you would also get some discharge as well. Acute angle closure glaucoma, you would end up with abnormal fundoscopy findings as well, because you have this raised intraocular pressure. And posterior uveitis would affect the retina and the choroid at the back of the eye. So with anterior uveitis, it's also known as irisitis. It's more common, and it affects just the iris of the eye. Presents with eye pain, redness, photosensitivity, and blurring of the vision, mainly because your iris can't, your pupils aren't contracting. It tends to be a bit more dilated because of the inflammation. And if it's left untreated, it can progress to things like glaucomas, cataracts, or even retinal detachment eventually. Okay, so I'm going to go through this fully, but this is quite a useful little flow diagram which I've picked off Google, which kind of goes through the pathways to kind of differentiate between the different eye pathologies. So ophthalmology is quite a big topic. So you need a whole separate session to go through it, but I just thought this was quite useful just for your revision to go through. But the main things that you want to consider when approaching a red eye is their possible trauma, see if there's any visual loss, if they've got any raised intraocular pressure or any pain. Look at their pupils, see if it's reactive or not, and then also use a slit lamp to look at the back of their eyes too. Okay. Then, cool. So this is one, your RAPD, so your relative afferent pupillary defect. This is something that took me a while to get my head around, and I think just about got my head around it by the time I got to finals. So with RAPD, it's looking for a decrease in the response to light in one eye, and if it's positive, that's with the decreased response in that one eye. And the causes usually are a retinal defect or disease, or there's some sort of defect to the optic nerve itself. So any sort of midbrain lesions usually ends up with an efferent defect, which means shining a light onto this eye would mean you don't get a response in the other eye. Yeah, I think this is the last question. Okay, so latanoprost is used in the management of primary open angle glaucoma. Which of the following describes the mechanism of action? I'll give you about 20 seconds for this. You get 5 more seconds. Okay, I'm going to close the poll now. So most people put down D, which is the correct answer. So your latanoprost increases your uvascleral outflow, and it's a prostaglandin analog. The other treatments that you have for open angle glaucoma is your topical beta blockers. So timolol is an example, carbonic anhydrase, so acetazolamide, it's another one that's commonly used, and any mitotics such as pilocarpines. And a lot of this you'll kind of just hear around and just remember the link to glaucoma. Just kind of going through the differences between open angle glaucoma is, so with open angle glaucoma, the iris is in the right position, and the uvascleral drainage canals are clear, but the trabecular meshwork isn't draining properly. Whereas in closed angle glaucoma, the iris is squeezed against the cornea, as you can see here, and it's blocking the drainage itself and the trabecular meshwork. So you get that increased pressure. Cool. And then I've just put this table in, which is from this thing called didact.me, which I thought was a really good set of notes as well for revision finals. And I just lifted this table off there, which because I thought it was a really good table of differentials for different causes of visual loss. So I've just put that in there for your revision as well to go through. So thank you for listening to me. I'm just going to pass on to Andrew.
Very fantastic title slide for you all. Now, I believe there is this QR code for the part 2 session.
Yeah, I'm going to post the link in the chat as well.
Fantastic.
And I apologise to those who may have joined later and didn't get to join the polls for mine. There you go.
Okay, so I think the session should be started. Let's see how many people join. Okay, and just as we wait for some people to join, we'll be covering not as many questions as before, which you'll be thankful to know. We'll be covering a few more niche subjects, and I'll just be going over some of the more salient points, what you need to know in terms of MCQs or what you should say in OSCEs or Viva type settings. And I'll try and be brief. Okay, I don't think anyone else is joining, so we can begin. But of course, if anyone has any questions, feel free to put them in the chat also. Okay, so let's start off then. Fantastic. Right. So just as before, I'll read out the question and you guys can answer. We're starting off with an easy one. So, a 55-year-old woman undergoing treatment for breast cancer makes an appointment with her oncologist. Over the last few weeks, she has noticed some new troubling symptoms. She has been experiencing headaches that are worse in the morning. She's frequently been tripping over at home. you perform a cranial nerve examination. Examining her eye, she complains of double vision, and on looking to the left side, you notice nystagmus or nystagmus with a slow beat. Which cranial nerve is being tested? Okay, I'll give a few seconds for some people to answer. Okay, I think that's pretty good. So let's stop the poll there. So of course the answer is D, which most of you got. Very good. So remember D, the abducens nerve or cranial nerve 6. It's a pure motor nerve. Its main function is to innervate the lateral rectus muscle, which causes abduction or abduction on the ipsilateral side. So you do get nystagmus and double vision if your eye movements become slightly incoordinated with an improperly innervated lateral rectus. Yes, so this slide shows us something about cerebellar disorders. So the history itself from the question could potentially point to something like raised intracranial pressure. It could point towards cerebellar disorders because the patient had a bit of a stumbling gait. But cranial nerve 6, especially in your SBA type questions, is usually associated with raised intracranial pressure. It does have quite a long intracranial course, which makes it susceptible to changes in intracranial pressure. But with malignancy and the potential for metastasis, we need to exclude other pathologies too. And one of them would be cerebellar disorders, of course. Now, in terms of the way that I think you should approach them for finals or for your exams is to split them into the acquired and hereditary causes when you're asked to present them. Of course, the most common cause of cerebellar disease is alcoholic cerebellar degeneration, which I'm sure you've seen on your hospital placements already. But there's other acquired causes too, notably things like stroke or traumatic brain injury, where you can directly damage or have infarction of the brain matter, multiple sclerosis and demyelinative disease, and things like neurodegenerative disorders and malignancy too. Of course, the acquired causes of cerebellar disease are more common, and your congenital or your hereditary causes are much more rare. Sometimes people talk about spinocerebellar ataxias or Friedreich's ataxia, which I won't go into too much today because they are very niche and very specific. Unless someone has questions about them, I'm happy to talk about them. But I think in the essence of time, we won't cover those today. But as this slide suggests, it's really important to recognize the signs of cerebellar disease, particularly how to examine them for OSCE. And there's this fantastic acronym which makes me hungry, Danish. This is a really important acronym to remember. So your D for dysdiadochokinesia, this inability to perform repetitive alternating movements, as well as dysmetria, where someone can't really navigate in space with their motor function, leading to past pointing or poor coordination in general. Your ataxia, in this case, think about broad-based stumbling gaits. Your nystagmus and intention tremor. The slurred staccato speech, which can be broadly labelled under dysarthria, you might hear in SBAs. And that's why in your cerebellar examination, we usually get patients to say things like baby hippopotamus and British Constitution. And finally, the H in Danish is for hypotonia. It's often a really subtle sign. It's slightly decreased muscle tone, It might not be obvious, but it's something to say. Okay, so the second question. A 54-year-old man presents to his GP with weakness in his left foot. It has been worsening over the last few months, and he is now tripping over when he walks. On examination of his lower limbs, he has weakness more towards the left side, atrophy of the right foot muscles, a positive left Babinski sign, and bilateral hyperreflexia, again with the left greater than the right. What is the most appropriate initial diagnostic test? And I'll give you guys a few seconds to answer. Okay, we have a bit of flitting back and forth. Just give it a few more seconds. Okay, let's stop the poll now. And I'll show you guys the correct answer, which in this case is actually B, electromyography. I think this question has caused a bit of contention in the audience, so let's go over it a bit. This question, of course, is quite a classic history for motor neuron disease. It has a mixture of lower motor neuron signs and upper motor neuron signs, and in any SBA, if you see a mix of upper and lower, you should always think about motor neuron disease, especially if it's at multiple levels throughout the body. So let's see what we've got here. Yes, so motor neuron disease in essence is a relentless progressive degeneration of both the upper and the lower motor neurons. Typically it causes things like random asymmetric symptoms in the hands or feet, and in SBAs will often progress to the facial muscles and the bulbar motor neurons, sorry, leading to things like difficulties in chewing, swallowing, or speaking. And of course, eventually it progresses to involve the respiratory muscles, which can often lead in death. The main diagnostic criteria for motor neuron disease are clinical evaluation and electric conduction studies. So your history taking and examination are really important in lots of these niche neurological diagnoses. So upper motor neuron and lower motor neuron signs. And then we move on to nerve conduction studies and electromyography to confirm the diagnosis. And usually that will be arranged at the neurology clinic. Of course, I understand when people say an MRI would be suitable to, I guess, rule out other diagnoses, but in an SBA setting especially, I believe they want you to think about motor neuron disease. And actually in neurology clinics, if we do suspect motor neuron disease, we'll often order the nerve conduction studies there and then. So it does have some real life backing. Of course, as this slide shows, motor neuron disease is actually a family of diseases, the most common of which is amyotrophic lateral sclerosis, which is the one that this question is presenting, with the mix of upper and lower signs in different body areas. And just in general, of course, the management of motor neuron disease, there is currently no cure, and the disease is progressive and relentless. but we still manage the patient's symptoms with supportive care, of course, using an MDT approach. We can manage patients' spasticity with baclofen, or if they have cramps, we can use quinine. You may have heard about this one drug called Riluzole. It's the only drug that's licensed to manage motor neuron disease in the UK. It doesn't cure the disease or reverse it, it just prolongs someone's life expectancy, or at least the time required until they require ventilation. And there's no other drugs that are currently licensed in the UK to manage this condition. Okay. Again, other potential diagnoses for motor neuron disease, think of the weird and wonderful, maybe things like Lyme disease or your bloodborne viruses like HIV or CNS lupus, but again, they're extremely rare. And for the upper and lower motor neuron signs, always think motor neuron disease in the first instance in your SBAs. And this is a very important table, just reminding you guys about the difference between upper and lower motor neuron lesions. Of course, the upper neuron lesions with your hypertonia, your hyperreflexia with positive Babinski sign, and your lower motor neuron lesions, typically they'll talk about atrophy or fasciculations. Okay, so moving on very swiftly to the next question. A 75-year-old woman sees her GP. She's noticed that over the last 6 months, her feet feel fuzzy. She describes this as feeling like she's walking on cotton wool. She feels otherwise well. Her past medical history is hypertension, type 2 diabetes, and hypercholesterolemia. In terms of her medication, she's on metformin, atorvastatin, ramipril, and verapamil, pretty standard stuff. What is likely to be the most appropriate step to help her symptoms, medication-wise, of course? Okay, so I would say just a few more seconds. Okay, I think we'll stop the poll here. So I'll show you the correct answer. It is B, to increase her metformin to the maximum dose of 1 gram twice a day. Now, I would say this question is a classic description of peripheral neuropathy, in the sensory sense at least. The fuzzy description or walking on cotton wool are really classic descriptions for the loss of sensation seen in peripheral neuropathy. And in this case, the presentation is typical of diabetic neuropathy. And so optimizing the patient's diabetes control should help to manage the peripheral neuropathy. Quinine in this case is usually given for cramps, at least in the SBA sense, which aren't described here. And gabapentin is usually used for neuropathic pain. In this history, there's not a lot of pain. So I want to talk very briefly about peripheral neuropathy. It could technically actually encompass any damage causing dysfunction to peripheral nerves. So it's important to distinguish what we mean by peripheral neuropathy. We could have a mononeuropathy causing foot drop due to damage of the common peroneal nerve, for example. But when we're talking about diabetic neuropathy, it's a polyneuropathy. And depending on the nerves affected, you can get different symptoms. So sensory neuropathies cause your paresthesia, your numbness, changes to proprioception causing loss of coordination. You have your motor neuropathies causing your muscle weakness or wasting or twitching. And finally, we have autonomic neuropathy, which we shouldn't forget, causing problems with blood pressure control, bowels or bladder, maybe giving patients a dry mouth or giving them temperature intolerance. And in something like diabetic neuropathy, we tend to damage the sensory, the motor and the autonomic system eventually. There's this really nice acronym. I do like this treadmills one, which is quite extensive. I'd say the most common cause of peripheral neuropathy is diabetic neuropathy, especially in your SBAs. But you may see other causes. I think quite commonly B12 and folate deficiency, alcohol excess. You may see your neuropathy. Injuries resulting in nerve damage like your crush or compression injuries. And again, lots of different infections like zoster, HIV or Lyme disease. But you may also see things like Guillain-Barré syndrome, usually patients presenting a few weeks after they've had a gastroenteritis or LRTI, coming in with a predominantly sensory neuropathy which starts in the feet and ascends upwards. There are hereditary peripheral neuropathies. The one that I think they like to bring in OSCEs is something called Charcot-Marie-Tooth disease, or also HSMN, or hereditary sensory motor neuropathy. It mimics diabetic neuropathy and most kind of glove and stocking type loss of sensation, but it's congenital, so patients are stable and they have signs. So it's an OSCE favorite for neurology. And of course, management of peripheral neuropathy is managing its underlying cause. Okay, fantastic. So we're speedily moving through just in the interest of time, but if you do have any questions, please do let me know. So question 4. A 33-year-old female presents to the headache clinic with poorly controlled migraines. She's been experiencing worsening headaches which have occurred daily for the past 3 months and describes taking her as required cocodamol and triptan every day at the maximum dose as her prescription allows. Lifestyle modification has not helped to relieve her headaches. What would be the most appropriate initial management for this patient's headache? Okay, just a few more seconds. Okay, good. Let's stop the poll there. And in this case, the correct answer is D, as the majority of you have suggested. This is a typical presentation of something that we call medication overuse headache. I think sometimes they call it analgesic headache these days. The history with a 3-month use of an opioid to control headache, which hasn't improved it, and the patient almost relying on it and taking it at maximum dose, is really typical for this type of headache. Unfortunately, the only way to manage medication overuse headache is by stopping the offending medication, And if you've ever been to a headache clinic and seen this type of patient, they're very reluctant to stop taking the analgesia. And I guess rightly so in some regards, as when they do stop taking that cocodamol in this case, they will experience some withdrawal and the headaches will probably get a bit worse before they get better. But this is a very typical presentation and it is a headache to be aware of. Remember, in the chronic pain setting, we shouldn't be using cocodamol for more than 3 months. That's not what it's designed for and shouldn't really control the patient's pain. So we need to stop the cocodamol and then potentially introduce another medication further down the line. Of course, the different types of headaches can pretty much encompass a whole lecture series on their own. I have created this table, which is loosely based on how we classify headaches in neurology. Of course, primary headaches are the more common ones, which you'll hear about a lot. Your tension type, migraine and cluster headaches, which I'm sure need no introduction. And then you've got your headaches secondary to a variety of other causes. Of course, the management of tension type headache, I'm sure we've all managed our own tension type headaches with simple analgesia. And I like to think about the way that migraine and cluster headaches are presented in SBAs. So migraine headaches are the type of headache that patients need to sit down or lie down in a dark room with low stimulation. So they want to sit in the dark and do nothing to manage their headache. But cluster headaches are the type of patients who are restless and pacing. In my experience, I've seen a gentleman hitting his head against the wall because his pain was so bad. So these presentations are often quite opposing in how they come across. The management of migraine headache is with analgesia, including triptan and lifestyle modification, because migraines can be triggered by all sorts of things. But cluster headaches, we can use triptans, usually subcutaneous triptans, to try and terminate the pain quickly, oxygen therapy, or medications like verapamil. Now, with a secondary headache, we need to use the surgical sieve essentially, because lots of different diseases can cause a headache as part of their symptomatology. We've got, I've written here, vascular, like your thromboembolism, your intracranial bleeding, your aneurysm or dissection, your infectious causes, and many, many others, and the list goes on and on. But I've put in those little red boxes some of the emergency headaches which you should not miss in your SBAs. Of course, your subarachnoid hemorrhage causing a thunderclap headache. But in the question, they're not going to use the word thunderclap. That would give it away. They'll talk about worst ever headache, which raises to the maximal intensity in a matter of seconds. It's a sudden onset. And sometimes they describe it as like a bat has been hit across the back of the head. So it's a severe occipital headache. Another important one is meningitis, where you are usually it's a pyrexial young person in SBAs with features of meningism, like your stiff neck, your photophobia, and maybe a rash. And of course, your stroke or TIA, which can present with pain and focal neurological deficit. I think another red box needs to be added, which is raised ICP, raised intracranial pressure, of course, which might be associated with vomiting, blurry vision, and papilledema if it's in the acute setting. Okay. So let's move on to the next question and speed on through. So a 17-year-old female attends the epilepsy clinic with her parents. Her mother showed you a video of the patient seeming to stare into space whilst repeatedly performing a grinding motion with her jaw, which lasts for about 60 seconds. She's unresponsive during the event and appears drowsy and weak afterwards. What is the most likely type of seizure based on the patient's clinical history? Okay, just a few more seconds. All right, let's stop it there, I think. So the correct answer in this case is D. This is most likely a complex partial seizure with a temporal onset. Now, any seizure with the grinding motion, the chewing, the fiddling of the hands, or the lip smacking, this is called a gestural automatism. It's really typical of temporal lobe epilepsy, and that's the most common, and those are the type of seizures that you'll hear about. The patient is unresponsive and they have a post-ictal state. It's very likely focal impaired awareness. And of course, they use this old terminology interchangeably, so it's worth knowing. Focal seizures are partial, and if they're impaired awareness, we call them complex, but if you have a focal aware, it's called simple partial. So yes, if it was simple, the patient probably would not have a post-ictal state afterwards. I'd say that's the main differential, and being completely unresponsive as well lends itself towards more of a complex partial seizure history. Right, so I've put this slide here with an EEG just to remind myself to talk about the diagnosis of epilepsy. So, of course, epilepsy is a predisposition for seizures. It's a seizure disorder, but not everyone who has a seizure we would classify as having epilepsy. In simple terms, if you've had 2 or more seizures that are unprovoked, that's pretty much what, at least in SBAs, we should define as epilepsy. But there are other causes of seizures, provoked seizures, especially due to things like alcohol or recreational drugs. The way that we diagnose a seizure or epilepsy truly is really based still on clinical judgment, as you'll find a lot in neurology. So based on the patient's history of their seizures, a video, or at least collateral history about what they look like, what was happening before and what was happening after, and excluding other potential diagnoses by doing neuroimaging like MRI or lab testing for things like meningitis with your lumbar puncture, or your drug levels for recreational drugs. A lot of people like talking about EEGs, and just like this EEG shows epileptiform activity, that can, of course, increase your suspicion of epilepsy. But remember that in the interictal period, when someone is not having a seizure, they might not have any epileptiform activity anyway. So the absence of EEG findings doesn't mean someone doesn't have epilepsy. The actual gold standard for epilepsy diagnosis is something called telemetry or video telemetry. It's a very intensive process indeed. We invite patients to come in, we stop their anti-epileptic medications, or at least reduce them, and we sleep deprive them to try and provoke a seizure. And when they do have a seizure, we have the EEG electrode stuck to their head, so we record their brain waves, so to speak, as they're having a seizure. Again, that's a very intensive process. We don't do it on everyone. The diagnosis of epilepsy is usually based on clinical judgment. And if someone is diagnosed with epilepsy, we may start them on anti-epileptic therapy. And again, this is my version of the International League Against Epilepsy's classification of epileptic disorders. Just remember, temporal lobe epilepsy is by far the most common. And in SBAs, usually it'll be your lip smacking, your chewing or grinding of the teeth. Sometimes they'll talk about frontal lobe epilepsy with its twitchy or jerky movement, or try and describe the figure of four posturing in very strange terminology. It's sometimes also called the fencer's posture or the fencing sign. And again, occipital and parietal lobe epilepsy are quite rare, so they don't usually talk about them in SBAs, but just so you're aware, parietal lobe epilepsy would be associated with primarily somatosensory symptoms, and occipital lobe epilepsy, if they do talk about it, it would usually be visual changes, so flashing lights, colors, or even visual loss. In terms of your generalized seizures, everyone knows about your generalized tonic-clonic seizures, the stiffening of all four limbs simultaneously, followed by a rhythmic jerking of all four limbs and potentially the epileptic cry. But there's other types of generalized seizures too, like absent seizures, which often look like daydreaming, and in your SBAs it will usually be a child who looks like they're unresponsive because they're daydreaming at school or at home, for example, and there's no post-ictal phase for those. And you may also hear about your atonic or drop seizures, and these are where there's a sudden loss in muscle tone. So again, usually in children, you see these children literally drop to the ground. If you ever meet these children, they usually have helmets because they're at risk of hurting their heads as they fall to the ground very suddenly. And finally here, I've put a very basic kind of slide showing you anti-epileptic drug therapy for the main types of seizures. In general, for generalized seizures, we give sodium valproate first line. And for focal seizures, we tend to give carbamazepine first line or lamotrigine. SBAs really love talking about the side effects of anti-epileptic drugs. And in particular, I want you to remember for sodium valproate, it is quite teratogenic. There are legal restrictions put in place about giving sodium valproate to women of childbearing age. If we do give it to women of childbearing age, they usually need to be on what NIHS calls a pregnancy prevention program, essentially strong contraceptive therapy. And we tend to only give sodium valproate to women of childbearing age as a last resort, where other anti-epileptics have failed or don't adequately control the patient's epilepsy. For carbamazepine, SBAs really like talking about its interaction with other drugs because it's a P450 inducer. But among other things, it can cause agranulocytosis, anemia, and sometimes, rarely, hyponatremia. And finally, here on the right, for lamotrigine, serious skin reactions like the Stevens-Johnson syndrome, toxic epidermal necrolysis spectrum of life-threatening skin reactions is a well-known side effect, as well as DRESS syndrome and hypersensitivity rash. Apart from that, it can cause problems with vision and movement. Okay, so if there's no questions, we'll swiftly move on to question 6. So a 69-year-old male attends the neurology clinic with symptoms of slowed movement, bilateral tremor, and muscular rigidity, which were unresponsive to levodopa therapy. The patient's daughter explained that her father had balance issues leading to multiple falls, where he seems to fall backwards. He was becoming more irritable and apathetic, not wanting to leave the house. On examination, you note the patient has difficulty following eye movements, especially vertical movement, and problems with blinking too. What is the most likely diagnosis based on the clinical history? Okay, just a few more seconds. All right, let's stop the poll there. Of course, you guys are absolutely correct. This is a very nice classic history for progressive supranuclear palsy. Features that point towards PSP are the Parkinsonism, which didn't respond to levodopa, making you think of a Parkinson's plus disease, the falling backwards, the difficulty with eye movements, vertical movements, and blinking, all point towards that PSP diagnosis. So remember, Parkinsonism is bradykinesia, rigidity, arresting tremor, and postural instability. And classically, that's associated with Parkinson's disease. But there are other syndromes which can be associated with Parkinsonism too. Sometimes it might be atypical Parkinsonism in your SBAs, where they might have most of the features, but the tremor isn't there, for example. Or they may have Parkinsonism which didn't respond to levodopa therapy, like a Parkinson's disease misdiagnosis. That's another common way which these SBAs are set up. And I've put the main Parkinson's plus syndromes in this table here. So on the top left, we have corticobasal degeneration, CBD. I always like to think about this in terms of the name. So cortico, there's degeneration of the cortex causing cognitive problems like behavior, language, or emotional problems. And then you have degeneration of the basal ganglia, which usually is associated with loss of use of one hand or the alien limb phenomenon. If you ever hear this description in SBAs, you should think corticobasal degeneration. Alien limb phenomenon is where the patients feel that their hand or their arm isn't their own and it's moving without their conscious control. On the top right, we have multiple systems atrophy, or MSA. The prominent features here are autonomic. So you'll have your Parkinsonism, but there'll be bowel or bladder problems or really poor blood pressure control. You may also get ataxia, so cerebellar ataxia, and speech impairment with MSA. We have PSP, which we've talked about. SBAs love to talk about falling backwards, problems with vertical movement or the gaze, and sometimes cognitive problems too, like with behavior and cognition. And then finally, as was previously talked about in the part 1 of this neurology session, dementia with Lewy bodies. We have our cognitive impairment, but we often get visual hallucinations, especially of animals or people, not usually inanimate objects. or maybe problems with REM sleep. And the dementia symptoms always precede the Parkinsonian symptoms. Now we move on to question 7. A 29-year-old gentleman is admitted to the emergency department after suffering a stab injury to the back of the neck. He is clinically stable but cannot move his left arm and leg. You decide to perform a complete neurological examination, the results of which are as follows: left-sided hemiparesis, loss of proprioception and vibration sensation in the left lower and left upper limbs, and right-sided loss of pain and temperature sensation at the level of the C8 dermatome and below. An MRI scan is ordered, revealing a lesion of the spinal cord. Based on the clinical history and examination, what is the most likely location of the lesion? Okay, just a few more seconds. Okay, let's stop the poll there. So the correct answer in this case is B, the left-sided C5, C6 hemisection. So this history is what we would call classic Brown-Séquard syndrome. And remember, Brown-Séquard syndrome is ipsilateral hemiparesis and an ipsilateral loss of proprioception and vibration sensation, and a contralateral loss of pain and temperature sensation 1 to 2 levels lower down than the level of the lesion. So the reason for this is we have to look at our spinal cord anatomy. So let's say we've destroyed the left side, as in this question here. So we destroy the left side. We have damaged our corticospinal tracts, carrying our motor function, causing hemiparesis on the ipsilateral side. We've disrupted our dorsal columns, causing a loss of proprioception and vibration sensation on the ipsilateral side. But for the spinothalamic tract, remember all our nociceptive fibers enter the spinal cord, then they move 1 to 2 levels up, then they synapse with a second order neuron which crosses over the spinal cord, and then the rest of the pathway heads up as the spinothalamic tract. That means you've damaged the spinothalamic tract, which controls the contralateral side. So you have a contralateral loss of pain and temperature sensation. Now, I've put this nice diagram here, and I've put 4 spinal cord syndromes, which you often see in single best answer questions. So I won't cover Brown-Séquard syndrome again, but anterior cord syndrome, or BEX, usually it spares the dorsal columns, so proprioception and vibration sensation are intact. For something like central cord syndrome, SBAs usually talk about trauma, not stab injuries per se, but things like people falling off their motorbike and landing on their neck. It doesn't cause a complete transverse section of the spinal cord to be disrupted, so they can still maintain some of their motor and sensory function. And in syringomyelia, we have this fluid cavity in the central canal, this fluid cavity pushes on the adjacent crossing fibers of the spinothalamic pathway, and so you tend to lose pain and temperature sensation, and it tends to cause a cape-like distribution of loss. Okay. And finally, in the essence of time, we'll go on to our last question. So a 34-year-old female attends her GP with fatigue. She describes feeling excessively tired after exercise or when exposed to the summer heat, and has a stumbling gait resulting in a fall at home. She also reports intermittent episodes of reduced visual acuity and pain around the right eye, which she attributes to her tiredness. Apart from an episode of a trapped nerve several years ago, there is no past medical history of note. Based on the clinical history, what diagnosis must be ruled out? And we've already got answers. Fantastic. Okay, I think that's fair enough. In the interest of time, let's stop the poll. And as you guys have said, the correct answer is C, multiple sclerosis. I do like this history. We have a presumed optic neuritis of the right eye. We have a roundabout way of describing Uthoff's phenomenon. And we have a potential previous demyelination episode, which means they could possibly have multiple sclerosis. Again, we wouldn't officially be able to diagnose them with MS based on this history, but it would definitely be in our differentials list. So just as a quick overview, multiple sclerosis is a demyelinating condition whereby we have demyelination of disseminated areas of the central nervous system, so the brain and the spinal cord, resulting in varied neurological deficits. It's thought to be related to neuroinflammation and potentially has an immune-mediated cause. Typically, and for the vast majority of patients with MS, will have a relapsing and remitting history of neurological deficit, which could involve abnormality of the cranial nerves, paresthesia, weakness, or spasticity, and it gradually results in disability over time. The diagnosis is made by the McDonald criteria, which essentially point out to make a diagnosis we want dissemination in space and dissemination in time. So dissemination in space means if we take an MRI, as this lovely T2 weighted scan shows, are there multiple areas containing these bright plaques of demyelination? And by dissemination in time, we mean on our MRI, do the lesions look like they have different ages? And in SBAs, they'll talk about gadolinium contrast to differentiate the ages of the plaques. Or of course, is the clinical history suggestive of multiple episodes? Some questions might also talk about oligoclonal bands, which are unmatched. That is, you'll see them in the CSF, but not in the serum. Again, the oligoclonal bands represent antibodies raised against myelin, which causes the demyelination, and that illustrates dissemination in time. In terms of history, Uthoff's phenomenon is quite common. This is intolerance to heat. So SBAs might talk about getting worse in the summer or after exercise or after a hot shower. Patients may also have Lhermitte's sign, which is the barber chair phenomenon. When they're bending their neck forward, they get shooting neuropathic pain in the neck, which is related to the inflammation in the central nervous system. And they might get optic neuritis, which is where they often have pain around one eye, potentially associated with visual changes, and the pain is with eye movements. Of course, multiple sclerosis will cause upper motor neuron signs because it affects the central nervous system. And finally, here we have the management of multiple sclerosis. I've put together this handy dandy set of 3. The way I would approach this in an OSCE or a Viva, I would say we want to manage the relapses with steroids, usually first line, but sometimes they do use Plex or plasma exchange or plasmapheresis, as it's sometimes called. These days we have disease-modifying therapy, especially with interferon beta or drugs like teriflunomide. But if someone's disease isn't controlled with interferon beta, or if they're having 2 or more relapses a year, we might start them on some monoclonal antibodies like natalizumab or crelizumab or alemtuzumab. And finally, we need to provide supportive therapy. Again, if they have spasm or spasticity, we can give them baclofen or physiotherapy, and exercise helps because these patients do become very fatigued. If they have neuropathic pain, we can give them gabapentin or other neuropathic pain medications like amitriptyline or carbamazepine. And if they develop problems with their bowel or bladder, we can use laxatives or urinary catheterization. Multiple sclerosis is also sometimes linked with depression, and so we could provide antidepressants or CBT. Okay, and that in essence is the management of multiple sclerosis, and with that I think we are done. So thank you very much for listening to my questions. I do appreciate it's very late, so to those who have stayed, I greatly appreciate it. It's been a pleasure to go through these questions this evening.